Sorry about that, Mr. Chairman. We're trying to do some math in the background on the fly. And this is for my brothers and sisters here on the committee. I think actually one of the things that always frustrates me is we sort of are mixing, is the colloquialism, oranges and apples. When you talk about the ACA was a financing bill. The Republican alternative was a financing bill. It was who got subsidized, who had to pay. And somehow we take joy saying we did this for people because we handed out more subsidies. I wish the committee would actually engage in something a little more intellectually robust and actually a discussion of not how we subsidize, but what we pay, not who pays it. And that's actually where some of this conversation could be actually much more robust and a lot more mathematically honest. Mr. Whaley, or Dr. Whaley, and forgive me if I mispronounced your name. I've been trying to dig through some of the RAND studies and those things. So I want to walk through first some concepts because you have one chart in here that sort of talks about, let's refer to it as subsidized cross-subsidization, transfer pricing. Private markets functionally subsidizing are dramatically more expensive than government paid for markets. So I have a Medicaid, Medicare population, sometimes my Indian health care services, my VA. But when I look at this chart, I mean, you have some here that the private pay market, 300% higher?
That's correct.
And is that some functionally, is that greed or is that a undercompensation from the government market into those populations?
That's actually one of the things we looked at and noted in my statement, is that variation is actually not tied to the share of patients that a hospital has that are, say, Medicare or Medicaid. The large difference in prices that we see illustrated in that chart really reflect differences in negotiation power and concentration in different markets. So some hospitals, whether it's just being the only game in town or acquiring other practices, are just really able to negotiate high prices.
So you got me to the punchline I was looking for, because in here, some of the RAND work was talking about one of the difficulties is sort of the collapse in competition because of consolidation.
That's correct.
Have you also worked through some of the data points of in healthcare markets, as if we dare use the word market and something it's where the majority of money comes through government? Do we have a sense of in highly concentrated markets, you know, single ownership or just one or two systems compared to any samples here in the United States where a market has lots of different providers, what we see in variance in the pricing just at that level?
One good example actually comes from the state of California. Northern California is very concentrated and dominated by a handful of providers. Southern California tends to have much more competition among hospitals. Hospital prices in Northern California are roughly double what they are in Southern California.
Say that last sentence again.
Hospital prices in Northern California are approximately double what they are in Southern California, which has a much more robust and competitive hospital.
So you believe that almost 100% variance in costs is just because of market concentration, lack of market concentration?
Correct.
Even with what CalPERS did of actually trying to do, you know, their experiment from a decade ago when they were going broke and trying to find the best low-cost provider.
That's exactly right. And the CalPERS reference-based pricing model was really designed as, given the level of market concentration and lack of competition in Northern California, how do you get patients out of higher-priced Northern California hospitals?
Look, many of us on our side as Republicans, we like concepts like HSAs and this and that because we see it as empowering the individual. But some of us have actually much more, I think, disruptive visions of the thing you can blow into in your home medicine cabinet that instantly tells you have the flu and could order your antivirals. Has RAND or anyone out there done a study of saying, okay, here's adding competition in our healthcare delivery systems, but my ability to have a breath biopsy, the thing on my wrist that manages my blood glucose, if obesity and diabetes are the #1 drivers of healthcare expenses in the United States, you would think as a group here, we would be passionate to talk about if 33% of healthcare is just diabetes, if maybe the #1 killer of prime-age young men is obesity, we would actually talk about things like that. Have you seen anyone start to do studies of that ability to almost have your own medical lab on your wrist?
Not quite to the same extent, but one really good example, and I think one of the benefits of price transparency is how it enables that type of innovation. So for example, we've done a study of a program that developed bundled payment programs, and so instead of kind of going across a variety of providers to get service, can everything be bundled into a single provider? And that type of innovation and use of price transparency reduced prices for surgical procedures by about 45%.
Interesting. Doctor, thank you. Thank you, Mr. Chairman.